All right, well, it's great to be here, and today I'm going to describe the results from our vaccine social media intervention trial. So just a little background, I think many of us are aware that a lot of parents in the US have concerns about vaccines. We hear phrases like vaccines overwhelm the immune system or children get too many vaccines in too short of a time. And as a consequence, about 10 to 15% of parents are requesting what we call alternative schedules, where they either space the vaccines out, they reduce the number of shots in a visit, they refuse certain doses, or refuse certain vaccines. Now, before I get into the background data that informed our intervention, I just want to briefly describe the setting in which it was collected. And we did this research at Kaiser Permanente, Colorado. It's a group model managed care organization, so it's an insurer and healthcare delivery system. We have about 700,000 members, 5,000 pregnant women, and 130,000 children are cared for each year, and it's demographically representative of the state of Colorado. And we also have an advanced electronic health record that we can use to identify patients, parents, recruit them into studies, follow them forward, and capture outcomes using the electronic health record. So before doing the intervention, we did some formative work, so focus groups and surveys with parents who had either accepted, refused, or delayed vaccines. And some of what we learned was new, and some of what we learned had been shown before. But most importantly, we learned that parents began thinking about vaccines during pregnancy, so they started that vaccine decision-making process early before the child was born, which obviously has implications for the timing of interventions. Not surprisingly, a lot of parents said they used the internet. We heard a lot about balance, which has been talked about the last couple days. Parents wanted to hear just as much for as just as much against vaccination, which is interesting because balance to us should reflect the state of the scientific data, which is much more for than against. So bridging that gap can be difficult. They said often there wasn't enough time with their pediatrician to discuss all their vaccine concerns. And whether they accepted, refused, or delayed vaccines, they expressed an overall trust in their doctor's advice on things like the physical exam, behavior, nutrition, diagnosing illness, but they expressed a much lower level of trust in their doctor's advice on vaccines. And again, this included even parents who had accepted vaccines. And recently, there was a survey conducted by Tracy Liu in Northern California, Kaiser. It was a nationally representative sample of about 1,200 parents, and she asked them about what could be improved about the vaccination process. And most parents, 51%, said nothing. They said everything's just fine. Of those who thought the process could be improved, the most common answer was vaccine information. They wanted better vaccine information. Among those who wanted better information, most wanted it, or the most common answers were they wanted it before the well-child visits, they wanted it early, and they wanted more information on safety. And so naturally, parents who are looking for that safety information early are going to go to the internet. What do we know about the internet as a source of vaccine information? There's a lot out there, and the quality varies significantly from government professional society websites, NIH, CDC, AAP for the US, all the way to parenting blogs and discussion forums. And what we know about the internet as a source of information is that these anti-vaccination websites and groups use anecdote and social media to disseminate misinformation. These blogs and discussion forums aren't moderated by experts, and the users are often anonymous. And we know through psychology studies that exposure to these anti-vaccine messages can intensify worries and reduce intentions to vaccinate. So what about using social media to address concerns for the positive? Well, this is the theoretical model that we use behind our intervention, and some of you may have seen this before. We call it the multi-directional communication model, or Web 2.0. It's got a top-down, bottom-up, and side-to-side component. So traditional Web 1.0 is the top-down component, where website developers just present the information and users can take it or leave it. Web 2.0 has this bottom-up component where users can create content and interact with the web developers. And then it has this side-to-side content where users can interact with each other. And so the idea is you create this dynamic, democratic online environment that engages the users through open discussion and idea sharing. And so we were hoping to be able to use this model to engage parents, build trust, reduce their concerns, and improve vaccination rates. So if you were to make a social media website to address parental concerns, you'd want it to be expert moderated. You'd want to provide a forum where parents could freely voice their concerns and ask questions. We would use it to build trust and combat misinformation. And so we asked ourselves before doing the intervention, can social media be used to reduce concerns and improve immunization rates? And this is what led to this study funded by AHRQ, Agency for Healthcare Research and Quality in the US. It's a randomized trial to evaluate the efficacy of a vaccine information website with interactive social media components. And it had 3 aims. We wanted to evaluate the intervention on immunization behavior, evaluate the intervention on knowledge, attitudes, and beliefs measured by a survey, and we wanted to assess efficacy separately in pregnant and postpartum enrollees to see if the timing of the intervention mattered. So this is a splash page to the website. It was created using focus groups, usability testing, and one-on-one interviews with parents and providers. And so we use this information to inform the design and content of the website. And I think one thing to keep in mind is we developed this about 7 or 8 years ago prior to the intervention, and at the time it was the latest and greatest theme. Today, if we were to implement it, we would have to update the look and feel, and I think this is one of the limitations of doing technology-based intervention research. The research is slow. You come up with the idea, you build it, you do the trial, you analyze the data. It could be 4, 5, 6 years later, and by then the technology has passed you by. But the idea was to build a website with vaccine information, but one that also had these interactive components, like a blog, discussion room, chat room, things designed to engage the users. And so all of the information was pro-vaccine, but it had a conversational tone. And so we wanted to draw those hesitant parents in, and then once they were in, we wanted to orient them to the right information. And we built it with this tab design, so people didn't have to scroll up and down. And I think maybe if we did it today, it would have a scroll design so it would be more conducive to a phone. And then it also had these, it also had these sort of buttons on each page. And the idea is if a parent was reading something and they had a concern or a question, they could quickly click on one of these and interact with the research team or other parents. And something that'll become a little bit more apparent as I move along is we created 2 versions of the website. One with vaccine information plus the interactive components, and one with just vaccine information. And this is just another page. So one concern that some parents have is around vaccine ingredients, namely aluminum and formaldehyde. And so what we did is we took all the vaccines on the Kaiser Permanente formulary, and we listed out all the ingredients in each vaccine. And then each ingredient was hyperlinked so the parent could click on it, learn why it's in vaccines, and whether or not there are any safety concerns. So we had 3 arms. We had the vaccine social media arm, the vaccine information arm, and usual care. The intervention was conducted over about a 3.5-year period. We recruited pregnant women as well as parents with young children. Upon recruitment, we screened for vaccine hesitancy using the OPAL PAC-V survey, and we created 2 strata of vaccine hesitancy. So the PAC-V survey measures hesitancy on a 100-point scale, 0 being non-hesitant, 100 being very hesitant. So what we said is if you scored 51 and greater, you were hesitant, 50 and lower, you were non-hesitant. Within each stratum, we randomized to one of the 3 arms that I mentioned, and we randomized at a 3 to 2 to 1 ratio. So that means for every 6 participants, 3 went to VSM, 2 went to the VI, and 2 went to usual care. And we did this sort of imbalanced design because it's known that of all the people who engage in social media, only a tiny % actually participate, post, engage. And so we wanted to get as many people in that VSM arm as possible. And importantly, it wasn't a publicly available website. It was an internally facing website. They needed a password and login to get into it. So participants were followed about 2 years, and these are the outcomes. Over the first 15 months, we administered a survey at baseline, 3 to 5 months, and 12 to 15 months when the child was those ages. We linked all of that information to the electronic health record to measure vaccination outcomes in the kids. In the pregnant enrollees, we looked at vaccination outcomes from birth to 200 days. And in the postpartum enrollees, we looked at vaccination outcomes from enrollment to 200 days. This is just a cartoon of the study design. So again, we would recruit patients. We would screen them using the PAC-V survey. Within each hesitancy strata, we would randomize them to one of 3 study arms. We would follow them until their children were born, and then we followed their children for up to 200 days to measure vaccination outcomes, and then we compared the vaccination outcomes across the arms. These are the vaccines that we analyzed. Up to polio are the infant vaccines through 6 months, and then as a secondary analysis, we looked at the 1-year vaccines, MMR and varicella. And to measure up-to-date status, we used a metric called days under vaccinated. It basically measures compliance with the recommended schedule. So it measures the distance between when a child got the vaccine versus when they should have gotten the vaccine according to the recommended schedule. So this is an example with DTaP. So the top represents the days at which a child is due for the first 2 doses of DTaP, days 93 and 154 days of age. The bottom is a child on a hypothetical delayed schedule. And so the numbers in the middle are the days delayed, and you simply sum up the days delayed, and for this child, they would be delayed for 66 days, and that's how we defined our outcome. We did an intent to treat analysis, so something I probably should have mentioned before is when patients or pregnant women were recruited, they were given access to the website, but we did not require them to visit it. And we wanted to simulate how it would be used in practice, meaning if a parent was in a well-child office and they needed more information, the provider would give them the web address but wouldn't require them to visit it. And then we analyzed the data with logistic regression. Up-to-date status was defined as 0 days under vaccinated, and not up-to-date was 1 or more days under vaccinated. And here's a cartoon of the knowledge, attitudes, and beliefs outcomes. It looks very similar. After recruitment, patients were given a baseline survey. Then after their child was 3 to 6 months of age, they were given a second survey, and then a third survey between 12 and 15 months. Yet another scale. So we used our own sort of homegrown survey that we developed using focus groups and a factor analysis. It comprised 18 questions measured on a 5-point Likert scale, and it had 3 different constructs: benefits of vaccinations, risk of vaccinations, and self-efficacy. And an example self-efficacy question would be, I have enough vaccine information, or I feel comfortable discussing vaccines with my provider. To analyze the KAB outcomes, we created summary scores for each construct. So if there were 3 questions and someone answered a 3, a 2, and a 1, their summary score would be a 7 or a 6, and we would model that summary score. We used linear mixed models for repeated measures because there were multiple surveys per person. We had 3 time points, 2 different time point comparisons, baseline to time 1, baseline to time 2, and we stratified the data by hesitancy status at baseline. Here's how we administered the intervention. We tried to update the content every month with 1 to 2 blog entries on vaccine-related topics. We tried to respond to questions within 48 hours. We created a newsletter that we sent every month that gave updates that told people about new items on the website. And the idea is we wanted to sort of juice traffic to the website. We had to moderate all the forums. We had to screen the comments, and then we tracked usage. As far as establishing trust and credibility, we always tried to present both sides. One of our messages was nothing is 100% safe. Vaccines have risks, so we tried to be upfront about the risks, but that the benefits greatly outweigh the risks. Again, we tried to respond to the questions quickly with tailored, personalized responses. We always acknowledged the parents' concerns. We tried not to exaggerate risks or benefits, and where possible, we tried to incorporate our personal experience into our posts and responses, so to tell stories like we've talked about. Transparency was a big issue. We learned this from our formative work, as you can imagine. So we had a detailed about me page describing who we were with our pictures. We were clear, well, so one thing, hesitant parents are skeptical of pharmaceutical industry and pharmaceutical companies, so we had to be clear that the website was being funded, or the research was being funded federally. We referenced all the materials so participants could see where we got the information, and we were clear that we were pro-vaccine, but that we would welcome all different types of opinions. We tried to use simple, short sentences, no more than 1 to 3 messages per block of information, and then we presented the information using an array of media. We used active voice and avoided jargon and scare tactics. Results. So we recruited about 21% of all pregnant women in the system. So our participants, 2/3 were pregnant, and then 1/3 were parents with very young children, and the hesitancy rate was about 14%, which is what we've seen in the literature before. And this is the distribution across the arms. Most participants were not hesitant, as I showed you before, so the mean hesitancy scale is 17. Mothers were about 32 years of age, about half were first-time parents. They tended to be white, college-educated, and internet-using population. This is a busy slide, but it just sort of gives an overview of the website usage. About 1/3 of the parents actually used the website. Users tended to be hesitant over non-hesitant. The average number of visits was 2 with a wide range, and out of 837 participants, there were 152 questions and comments. Most comments were about the schedule and safety. You know, we didn't see any vitriol or excessive negativity. So going into this, we thought we would encounter parents who wanted to argue and spread misinformation. But we really didn't see any of that. And I guess in retrospect, it makes sense because the website was being administered by their healthcare provider, and participants were not anonymous. So they knew, we knew who they were. And so I think this probably, you know, it dissuaded those who wanted to be negative, right? It sort of attracted the people who had legitimate questions, who may have been on the fence, but it sort of pushed away those who wanted to be really negative. And I think this is a good sign because it suggests that if we were to implement this in practice, it would be a resource for those parents who are just sort of on the fence rather than those who wanted to use it as a soapbox to express their anti-vaccine views. Some of the questions were really complex and took hours to answer. So, for example, one parent came across a blog by an anti-vaccine physician who wrote a really long article about how measles wasn't a serious disease and about how it could be cured with vitamin C. And the article was just larded up with all these scientific references, and it looked legitimate. And so we had to go to the article, we had to read it, we had to access some of the material, we had to interpret it, and then we had to debunk it in an easy-to-read manner. And it took a long time, it took hours. And so we got a lot of questions like this. The chats that we hosted were sporadically attended, about half. When they were attended, they were lively and participants had a lot of questions, and we often had to cut them off after an hour. But again, they weren't all always attended. And participants preferred to interact with the research team and not with each other. And so here are the quantitative results. So in the social media arm, the up-to-date status was about 93%, as compared to 86.6% in the usual care, for a difference of about 5 to 6%. And translated into an odds ratio, individuals in the vaccine social media arm were about twice as likely to be up to date than those in the usual care arm. So it was effective. However, the results were not effective in the postpartum enrollees. It was only effective in the pregnant enrollees. And these are sort of the cherry-picked results from the survey. So I have the three different constructs: benefit, safety, and self-efficacy. From time 0 to time 1, beliefs in the benefit of vaccinations increased at a greater rate in the VSM arm compared to usual care. Similarly, they increased at a greater rate in the VI arm to the usual care. For safety, From time 0 to time 2, concerns about safety decreased at a greater rate in the social media arm compared to usual care, and at a greater rate from the vaccine information arm to the usual care. And for self-efficacy, it was only effective in the vaccine information arm. From T0 to T2, self-efficacy increased at a greater rate in the VI compared to usual care. So in conclusion, at least from this intervention, infants exposed to the VSM intervention were more likely to be vaccinated on time than those in usual care. Both interventions were only effective in pregnant enrollees, and so the timing of the information seems to be important. It had a lot of notable limitations. We saw very little participant-to-participant interactions. Our goal was to create this online community with parents, but they weren't all that interested in interacting with each other. They just wanted to interact with the research team. This was conducted in a single health center at the US, so it's not clear how generalizable these results will be. So if we let this out to the public, would it have the same effect? It might not. And you know, you would think because this was an online intervention, it would be cost effective because it's a website, but I'm not convinced we're doing a cost analysis, and I'm not so sure it's going to be all that cost effective. We needed a dedicated expert research team to sort of hover over it, to monitor it, to update the content, to answer questions. So I wouldn't say it's an inexpensive intervention. And I'd just like to acknowledge the study team that worked really hard on this project. Okay, that's it.